Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging at Memorial Sloan Kettering Cancer Center, and I'm also Vice Chair of Education, and I'm a Professor of Radiology at Cornell Medical College in New York. What is RECIST and when is it used in thoracic cancers? RECIST is an abbreviation for the term Response Evaluation Criteria in Solid Tumors. The newest version is the updated version, which is RECIST 1.1. It is a guideline that describes a standard approach for objective assessment of change in tumor size, which is used in cancer clinical trials. CT is the preferred modality to include in the RECIST criteria. However, PET-CT can also be used in the detection of new lesions. How do we select lesions? First of all, in order to use RECIST in a trial, you have to have measurable disease. And what we mean by measurable disease is target lesions. We usually pick 5 target lesions, which is the maximum number, of which 2 at most can be in one organ. Generally, you would pick the largest lesions, and lesions have to be at least 1 centimeter in size in the longest diameter. We could also include lymph nodes, which have to be at least 1.5 centimeter in short axis. And we use unidimensional measurements. So the longest diameter is used for all lesions, while for lymph nodes, it's the short axis diameter. We can also include non-target lesions, which essentially are not measurable lesions, such as fluid in ascites or pleural effusion or pericardial effusion, or lymphangitic carcinomatosis, which is hard to measure distinctly, and it's more of an infiltrative appearance. We can also include lesions that do not meet the size criteria of 1 centimeter or lymph nodes at 1.5. We can also include lesions beyond the maximum number of 5 if there's a lot of disease elsewhere and we'd like to include that. So essentially we have target lesions and non-target lesions. The way we assess response is in 4 categories. Complete response, which can indicate disappearance of all target lesions, and also disappearance or decrease in the lymph nodes to a measurement of less than 10 millimeters in short axis. Partial response is a second category we could assess, which would be a greater than 30% decrease in the sum of diameters since the baseline, and we would have no new lesions. The third category is stable disease, which is neither partial response nor progressive disease. And the last or fourth category would be progressive disease, which represents a more than 20% increase in the sum of diameters of target lesions since nadir, and an absolute increase of greater than 5 millimeters. Or the appearance of any new lesion would make this automatic progressive disease. So new lesions, even if the other lesions have not changed, would make the response as progressive disease. Now, what about intra or inter-observer variability in measurement? We generally try to keep the same person assigned to a clinical trial for RECIST measurements. The RECIST measurement is separate from the clinical report because you select specific targets. But we did look at our institution at numerous measurements, over 1,000 measurements, and published that and showed that inter and intra-observer variability rates were similar, and we could safely perform measurements by different radiologists. So if you need to assign a few radiologists to a trial, it's safe to assume that the measurements will be within an accurate range.